good afternoon, good evening, everybody. I'm Dr. Puckett. Would like to thank you for getting online today and hearing this seminar and hopefully learning a little bit about ourselves and loved ones and things that can happen. Certainly during this webinar, if you have any questions or anything you'd like to ask me towards the end, we're going to have a period of time where you can ask questions, and please type those in and we'll get back to you towards the end of the presentation. Obviously, I can't stop in the middle for specific questions, but would be more than happy to address any questions that we have. Not doing it. All right, so today we're going to be talking about elbow pain. So I entitled this one, "My Elbow Hurts," which is a pretty common question that I get, and it's pretty common problems to have. They seem to be somewhat seasonal, but we'll talk about some specific ones, some very common ones, and basically how we go about treating those. Fortunately, most of the time we can treat those without surgery, which is really a wonderful thing. But as with most elbow, wrist, and hand pain, the sooner that you're seeing a specialist to get it evaluated and get on a treatment plan, generally the better and more quickly those problems get better, but we'll talk the specifics. So our objectives today is understanding the basics of elbow anatomy and function, understanding the common causes of elbow pain and dysfunction, which means problems, and understanding treatment options and the importance of conservative treatment, particularly in treating with the elbow. There are some specifics where surgery is really the most important way to take care of the problem, but in the elbow, those are relatively uncommon, and most of the time we can get excellent results and improvement in pain and function with conservative treatment alone. We're going to talk a little bit about the complex articulation of the distal humerus, proximal ulna, and proximal radius. This is the elbow joint. We often think of it as a hinge, just kind of flexion and extension. But if you rotate your wrist and turn your palm up and palm down, that motion is actually part of the elbow as well. And so I'd like to point out a couple of important parts of this mechanism, and I'll do that in the next slide, to help understand kind of the mechanical structure of what we're taking care of and why it can be challenging to find the problems in the elbow. So I'll go back one slide real quick. The three articulations are what we call the ulnohumeral joint, the radiocapitellar joint, and the proximal radioulnar joint. And so getting a little bit closer on this camera or on this picture, and I'm moving the mouse over on the left-hand side, we have the humerus. This is the long bone that extends from the shoulder to the elbow itself. That is the kind of anchor for the elbow and the forearm. And then if we go to this upper right-hand slide, where the arrow, the pointer is right now, that is the ulnohumeral joint and is responsible for the hinge function of our elbow. So that's the flexion extension, the bending and the straightening. And then the kind of on the left side of that same picture, and this is looking at the elbow from the front, this is what we call the head of the radius, and it's what allows the rotation of the forearm as well. In between the radius, which is this bone right there, shaped like the top of a golf tee, and the ulna, which is the back of the bone on the back of your elbow, we have the proximal radioulnar joint, which is right in the middle, which allows this rotation of the wrist. And so the wrist motion actually begins at the elbow, which adds to the complexity of it, and which is, again, why it can be tricky to find the problems with. As we go to the muscular anatomy, the primary function of the elbow in regards to the muscles is to provide the anchor for the motors of the wrist and the hand. So our wrist function, both flexion, extension, moving, grip strength, all of these things actually start with muscles and with tendons that begin and anchor in the elbow itself. On this upper left-hand side, this is the inner part of the elbow, so more towards your hip. And we have the muscles on this inner side, and those are the beginning point for the muscles that allow us to make a fist and to lift heavy objects. On this lower picture, we have the outer part, and in particular, we have these muscles in through here. These are the anchor points for the muscles that extend our wrist and straighten our fingers. So the function of the hand and the wrist actually begins in the elbow, which makes elbow pain so much more difficult to deal with because compensating for that pain can become very challenging on both the wrist, the hand, and the shoulder itself. Ligamentous structures, we won't go into too much detail, except to say that on this side and through here, we have, this is the inner part, again, near the hip, and we have the anterior bundle of the medial collateral or ulnar collateral ligament, as well as the transverse ligament and this bundle in between, which is more like a fan. On the outer part of the elbow, we have ligamentous structures, the lateral collateral ligament in particular, and the radial collateral ligament that make up stability on the outer part of the elbow. We have three important nerves that cross the elbow itself. They are the median nerve. Most people know that one because that's the one that causes carpal tunnel syndrome. The ulnar nerve, which is causes a problem that is known as cubital tunnel syndrome. And that one is, we affectionately call the funny bone nerve. Not always so funny when we bang it into a countertop, but certainly important. And we're going to talk about that one specifically in more detail. And the radial nerve, a particular part of it that the doctors call the posterior interosseous nerve. And we're going to talk about that problem in more detail as well. The radial nerve is what allows us to extend our fingers and our wrist as far as the nerve supply to it. So we're going to start with the most common thing that I see when someone comes to me with elbow pain, and that is what we call lateral epicondylitis. Lateral epicondylitis is pain on the outer part of your elbow, the part facing away from your body, and it is probably the most common cause of elbow pain. We see a lot of this in the springtime, usually early summer, late spring, and generally it's associated with use and cleaning in the yard, mulching, lifting, mowing, weed whacking, all those things that those of us in Florida certainly are familiar with. And once it starts happening, it can be very challenging to take care of early. It can be very challenging to get better with conservative treatment like medication and rest. And generally about 6 weeks later, people are in my office with concerns because their elbow still hurts. Can be exacerbated means aggravated or made worse by an injury. That is usually direct contact with something like the outside of a door frame. As we're walking through, we bang the outside of our elbow, which certainly happens to me fairly commonly, and then initiates pain in the elbow that does not get better over time. Shoulder injuries, rotator cuff surgery, conditions that cause pain or stiffness in the shoulder can cause us to have increased pain in our elbow because of compensation from the shoulder not being able to go through its normal range of motion. So elbow injury, elbow pain, and elbow problems can follow shoulder problems. It's a very common linkage. So diagnosis for physical exam. In this picture, we have a good example of how we diagnose that. And that is this patient, which is the arm on the right, is trying to extend their wrist or pull their wrist back, bring their fingernails more towards their head with resistance, meaning the other participant, who is the examiner with the watch on the hand, is pushing the hand down. So when we're resisting that downward motion by pulling the hand back, that causes pain in the elbow, and it is probably the most important clinical finding. Lateral epicondyle is that bump on the outside of our elbow. This is a picture, of course, while we're covered with skin. And that is the location generally of where that pain is. It can sometimes radiate or extend down across the forearm and can sometimes track along the back of the elbow across the bicep as well, or tricep. But generally speaking, it is started at the outside of the elbow. And most people can point exactly to where the pain is the worst. We can confirm the diagnosis of this with an MRI. These are two MRI pictures, and on the left one, we can see the fluid in between the torn tendon, which is the part in dark and black, and the bone, which is also in black. This is the cortex, or the hard shell on the outside of our bone. And in between that, we can see this fluid, which is either bleeding or fluid from the joint that has crept into that space. I often compare this to wallpaper peeling off of a wall. It does not happen always with a complete tear at one time with a pop. It very often peels from one side, usually this top side closer to the shoulder, and kind of peels its way down as it goes. This picture on the right, we see this, instead of seeing nice, dark, healthy tendon, we see this kind of whitish, less solid appearing tendon. And in this part, this is also that lateral epicondylitis. This is showing us a condition we call tendinosis, which is wear and tear and damage within that tendon without a tear, as in the left picture. This is a picture of a complete tear. And we can see that there's this complete space and this complete gap with bleeding and extra fluid in the joint itself. But we can see that the dark anchor in this point, or the tendon and anchor here, is no longer attached to the bone where it started. This is usually a much more dramatic type finding, and usually it necessitates a surgical repair with an anchor to repair that tendon. This kind of tear is much more uncommon and usually much more dramatic from a fall, from a direct injury. Treatment, fortunately, physical therapy with an occupational therapist is really the mainstay of treatment for lateral epicondylitis. And the success rates on that can be upwards of 90% or more in the hands of a skilled occupational therapist. I specifically have a list of people that I like using, and skilled therapists we send my patients to, including our own therapist. But we want to make sure that you're in the hands of somebody that knows how to handle this problem. The treatment is mostly with techniques that increase blood supply to that tendon to increase healing, relieve pain, and then stretching to improve the range of motion of the wrist and allow a healthier tendon and muscle flexibility to try to prevent this from recurring in the future or coming back. Other conservative measures, stretching. So when I'm seeing patients in the office and I diagnose them with lateral epicondylitis, I go through a routine of how to stretch and kind of improve not only the range of motion, but the tendon health and muscle health in that group, in that muscle group, to try to prevent this lateral epicondylitis from returning. I myself have had lateral epicondylitis on both arms. And since I diagnosed it in myself and I've begun stretching after I feel the beginning of symptoms, usually those symptoms are gone within 24 to 48 hours, as opposed to having those symptoms worsen over weeks and months. Deep tissue work, that's done in the hands of a therapist, and they have several techniques to improve the blood supply to that tendon group to allow improved healing. Ultrasound and iontophoresis are other techniques they will use. Strengthening usually comes later, and focusing on conditioning in particular with low resistance type weights and bands to prevent further injury to the lateral epicondyle and those extensor tendons. But trying to improve muscle health and prevent the problem from coming back. The patient education and focus on activating the bicep. That is, when diagnosed with lateral epicondylitis, the bicep muscle is critical to preventing aggravation of this problem, as well as preventing it in the future. And by activating the bicep, we are turning our palm up and lifting with our elbow using the palm up as opposed to the palm down. The terms for that are pronation and supination. Just the important one is palm up is always better for the lateral epicondyle. Bracing can be used as well. This is probably my least favorite way. And walking around shopping centers and grocery stores, you'll see people wearing these braces. And if you see them 6 months later, they're very often still wearing the braces. They can certainly help, but they can cause problems. And I'll talk about that with another condition of the elbow later on. Stretching, good mechanics when lifting objects, physical therapy generally works better than bracing. Injections, there had to be a picture with a needle since we're talking about orthopedics. Cortisone injections in the lateral epicondyle can improve pain, but can also on occasion cause damage to the tendon itself. And when the pain returns, can be a more torn tendon as visible on an MRI. Generally, I try to shy away from injections except for in extreme examples and circumstances for fear of not only recurrence, but also the fear of damaging the tendon itself and changing our opportunity for a complete recovery. Another injection, which is becoming more popular, is platelet-rich plasma, or PRP. What that is doing is increasing the healing response within the lateral epicondyle and the tendon in that location, and can certainly be a viable option for conservative treatment for the lateral epicondyle as well. Autologous stem cells, which are cells from our body, which can then stimulate healing and become some of the healing tissue in the tendon itself. Those are usually harvested from our bone marrow, from our blood, or from our fat cells. Surgery, so a debridement means removing the damaged part of the tendon, and referring back to those MRIs, that would be the portion which is not dark, solid, and healthy looking, is removing the damaged part, taking the healthy part of the tendon, the healthy tissue, and repairing that healthy tissue back onto the bone itself. And there are several different techniques to do this, most of which are effective. The key is removing the damaged part of the tendon. The importance of talking about surgical repair in this circumstance is surgical repair is always an option, and the success rates on that are actually quite high when the diagnosis is correct with lateral epicondylitis. But it is the last option that we go through, and it is actually a very infrequent option compared to the number of patients that I care for with lateral epicondylitis. But the key is, with elbow pain, there is almost always a solution. We start with the simple, more conservative solutions first. Surgical solutions can't be an option after that. Radial tunnel syndrome. So the radial nerve, which is one of the three nerves passing the elbow, can also be compressed in the elbow. There are going to be some pictures coming up which can be a little bit disorienting, but I'll go through my best to show you the actual anatomy and what the problem is. The importance of radial tunnel syndrome is it can cause pain on the outside of the elbow that runs down the top of the forearm into the back of the wrist. That pain can be difficult to pinpoint. It can feel different for different people, but generally speaking, it can be the pain that, even with lateral epicondylitis being improved, it can be the pain that continues. The key to distinguishing between lateral epicondylitis and radial tunnel syndrome for the patient themselves is really quite simple. Pain in our forearm and on the outside of our elbow when we are at rest, when we're not working, when we're not picking things up, when we're trying to go to sleep at nighttime, that pain is generally radial tunnel syndrome. The pain when we're picking up a bag of mulch or taking out the trash, that is generally the lateral epicondylitis. Activity-related pain is tendonitis. Pain at rest is generally nerve-related pain. Radial tunnel syndrome is really probably quite common because it can hide in the background of other problems. Part of a thorough evaluation of elbow pain would involve also evaluating for radial tunnel syndrome. That can be the source of a failure of treatment requiring a surgery that then does not solve the problem. So identifying radial tunnel syndrome is actually quite important. Radial tunnel syndrome, again, frequently described as aching and burning, which many types of nerve pain is, often worse in evening, interferes with sleep, not particularly aggravated by activity, pain on the dorsal wrist to just above the elbow on the lateral or outer side. Anatomy here, I know this is a lot of spaghetti all running down the arm and can be a little bit tricky to identify, but the importance is this is the shoulder up at the top of the diagram. And we have the radial nerve, which runs behind the arm where the triceps is, runs along the side in through here, comes down in through here to the front of the elbow, and sends this branch right across in through here. And that branch is what the part of the nerve that gets compressed itself is right in the front of the elbow. And I'll show you more diagrams just demonstrating kind of exactly where that would be. In this picture, this is going to be a little bit more kind of focused on the point in question. The radial nerve is running on the outer part of the arm in through here, sends a branch, which is this one right in through here, running beneath this muscle. This muscle is called the supinator, and it's in the muscle on the outside of the elbow, just past the hinge. This area right in through the spot and this supinator muscle, you'll see this seam right through here. The supinator is made up of two layers. We call them heads. And it's very much like a sandwich. There are two layers of bread. Those two layers of bread are the two layers of the supinator. The nerve itself, called the posterior interosseous nerve, runs in between the two layers. So that would be, the ham or the cheese in the bread. There's another picture of the importance of this picture. This is from Gray's Anatomy, of our kind of early anatomy textbook. The point of going through this is there are several different locations that this nerve can be compressed. And in this picture on the right, it is nerve running on the front of the elbow, going through the supinator muscle again, and running down through the forearm. There are numerous places in this location where that nerve can be compressed. And so being in the hands of someone that has experience with decompressing this nerve is actually quite critical. On exam, we have the third finger test. So that would be similar to the resisted wrist extension test, except in this particular example, we are resisting the extension of specifically the middle finger. The fibers of the muscle that extend that finger run closer to the nerve and can aggravate the pain in it. The other location is tenderness, and that is on the outside of the elbow. That would be right in here. Tenderness in that location causing symptoms, burning and tingling in the forearm can absolutely be a sign for radial tunnel syndrome. It can be often very difficult to diagnose, especially in the context of other elbow pain and symptoms, which is why a good, thorough physical examination of the elbows for this problem in particular is very critical. Conservative treatment, fortunately, again, conservative treatment is significantly effective in the treatment of radial tunnel syndrome and can make the symptoms completely vanish, sometimes even before 6 weeks of therapy. Stretching, mobilization of the supinator muscles, those are the two layers of bread, and breaking up muscle adhesions. So that would be sticky spots, almost like cobwebs between these two layers that make it less possible for the nerve to be nice and cushioned and padded in its environment. We want to improve range of motion. As patients with chronic elbow pain very often have extension loss, which is straightening the elbow, we want to make sure that the muscles and the tendons are flexible, because that's critically important to not only resolving the pain and symptoms, but preventing them from happening again. And we also want to address lateral epicondylitis when it exists in coordination with radial tunnel syndrome, because again, they can often go together. Surgical treatment is release of the posterior interosseous nerve, affectionately called the pin. That in that surgery, we are releasing the top layer of bread. So we're not taking away muscle strength. We're not taking away function by doing so. We are only releasing the top layer of that. So the muscle function of that supinator muscle still remains. And here's a lovely picture with all kinds of stuff and all kinds of arrows, but I'll go through the important part, which is the radial nerve in the front of the elbow. This is our bicep muscle in the front of the elbow and our bicep tendon. And that nerve branches and forms the posterior interosseous nerve branch here. And in this picture, we see the supinator muscle, which is this, and the splitting of that top layer of the bread to relieve pressure on that nerve. The point of greatest compression is very often at the beginning of that slice of bread, which would be where the crust is. And the results on that surgical release are quite good when the problem is radial tunnel syndrome. And now on to a very common problem on the elbow, which is cubital tunnel syndrome. This is a very common source of pain, numbness, and tingling in the elbow, and including the pinky and ring finger down in the hand. This nerve runs on the inside or the medial side of the elbow, which is closer to our body. The pain and problems with this nerve can actually be quite insidious, and the symptoms can range from light numbness to tingling to muscle weakness and difficulty fastening buttons, tying knots, or a tie as I'm wearing right now. So proper evaluation, again, is very important whenever there are concerns about elbow pain and problems. But those elbow pain and problems can even extend to the pinky and the ring finger and still be related to the nerve in the elbow. Also, the cubital tunnel syndrome can be quite painful. That is more common after an injury, a direct impact, like on a countertop or in the shower, which is generally where I bang into it, but also can happen as an injury and a fall on an outstretched hand, hitting the palm and causing an injury in the elbow as well. Ulnar nerve anatomy, fortunately, the ulnar nerve is a lot simpler in the elbow. It sends off very few branches, and it really just runs along the posterior part of the elbow, right in through here, along the inner part, the medial part next to our body, and runs down to the wrist on the palm side and goes to the pinky and the ring finger. As we look at the inner part of the elbow, or the medial part of our elbow, This is the bump or the knob on the inner part of the elbow called the medial epicondyle. The nerve runs behind the elbow and the arm, runs through a groove right here. That's that little notch where our funny bone is, and then runs under the muscle in the forearm where it's well protected. Unfortunately, right where that muscle is tends to be where it gets the greatest compression and has the most problems. On physical exam, lots of things can happen with cubital tunnel syndrome. Again, that ulnar nerve actually is quite important for the function of our hands. So it can give us decreased sensation to 4 and 5, that would be the pinky and the ring finger, and to the back of the hand on the pinky side. So that would be this side on the pinky side of the hand. Weakness in what we call the first dorsal interosseous muscle, that is the muscle right here in between our thumb and our index finger. This muscle is important for pinching, but also for fastening small things, picking up small screws, and picking up coins and doing small fidgety things with our fingers. That is entirely a function of the nerve, the funny bone nerve, or the ulnar nerve in the elbow. Another physical exam finding would be what we call a claw hand, and I have several examples of that. That is widening of the palm. If we look at this right hand, the palm is very wide. This one is more cupped and more normal. This involves very severe injury to the ulnar nerve, as well as widening of the space between the pinky finger and ring finger. A claw hand, this is another good example of what a claw hand appears like. It is clawing or bending of these two fingers, while the other two fingers, the index and middle finger, remain effectively normal. On this right-hand picture, we have clawing or bending of this finger, slight bending of this finger, and a normal middle and ring finger. We also see some loss of that muscle, the first dorsal interosseous muscle between the index finger and the thumb. That is also a sign of great concern as far as ulnar nerve function. When I see a patient like this, I get very concerned. We start accelerating treatment because we need to get the pressure off of that nerve so we can have recovery. On this lower left side, we see the generalized area of where that sensation from the funny bone nerve or the ulnar nerve actually is. Testing in the office, pressure directly on that funny bone nerve spot. The problem with being a doctor that takes care of elbow pain is generally elbow pain. The diagnosis of it involves pushing hard on the parts that hurt. And I always feel bad about hurting things that already were hurting to begin with. But this is one of those times that it really is quite necessary. What we're looking for with this elbow compression test is pressure on this nerve to increase symptoms in the forearm and in the hand and pinky itself. A positive test or a sign of cubital tunnel syndrome would be symptoms that are made worse by pushing on this location. Generalized treatment, activity modification is quite an important one. Very often in our daily lives, we're putting pressure directly on the inner part of our elbow, either armrests on a chair, which I do quite frequently, on a table, good table manners, even good comfortable chairs as we're relaxing and watching TV can put direct pressure on the inner side of the elbow, causing that nerve to kind of go on the blink, kind of like a blackout. That creates numbness and tingling in the pinky and ring finger. We generally drop our hand, shake it out, it gets better, and then we go back to, at least if it's me, go back to putting our elbow back on the table. Night bracing. This is a technique where we are trying to keep the elbow extended at nighttime while we're sleeping to relieve pressure on the nerve while we're asleep. The problem is these types of braces generally turn our elbow into a flipper, almost fully extended, which can make it quite uncomfortable to sleep in. I've had much less success with night bracing and generally focus on activity modification, physical therapy, and surgical decompression when necessary. An EMG, this is a nerve conduction test and a muscle test. What we're looking for is overall nerve health. We're getting a roadmap of the nerves from the fingertips to the shoulder and the neck, and we're looking for traffic jams. This would be a location where the traffic jam is on the inner part of the elbow with the ulnar nerve, and it also gives us a very good idea of how healthy that nerve is, so we know how aggressive we need to be as far as decompressing it so it can recover, and that would be surgically taking the pressure off of it so it can recover. If the nerve is quite sick, time is really quite critical. the sooner we can get the pressure off of the nerve, the faster and more meaningfully we can have a recovery. The types of surgical releases when it comes time for surgery, if necessary, one of them is what we'll call an in situ release. That means in place. An in situ release means we are leaving the nerve as it sits. We're not moving it into a new location. We are just taking the pressure off of it. After that, we have no particular precautions after surgery. People actually recover quite quickly as far as the surgical site itself, and stitches generally are in about a week and a half. The second surgical treatment would be an anterior transposition, which is a much larger procedure where we are moving the location of the nerve from the back of the nerve to the front, or back of the elbow to the front of the elbow. As you can imagine, the nerve would likely want to be where it was born, not necessarily move to a new location. So that is a surgery that we do for very extreme circumstances. And if we have to redo or revise a nerve decompression or a nerve release. This is a diagram of the structures involved in a nerve release. I would certainly hope that nobody's getting a nerve release to this extent. This is more for information than anything else. In modern methods, our nerve releases for the inner part of the elbow and the cubital tunnel syndrome generally are not much greater than an inch in length, and usually only 3 stitches is needed to sew that incision up. But we can see the ulnar nerve running along the inner part of the elbow, behind the knob on the inner part of the elbow, the medial epicondyle, running through a ligament, and then through the flexor carpi ulnaris muscle, which is right in through here. A decompression would be a decompression from all the way in the back of the elbow here to the forearm just past the elbow, but this can be done through very minimally invasive means. The next topic would be something a little bit more urgent, and this would be a distal bicep tendon rupture. The bicep tendon is the large muscle and the large tendon in the front of our arm that runs between the shoulder and the front of the elbow. The distal part, which is the part closest to the elbow, it's the end of that bicep muscle where it anchors into the radius bone in the forearm. That's what allows us our great elbow strength and allows us to rotate our wrist with force. The best example would be turning a screw with a screwdriver or opening a thick jar of pickles, for example. The distal biceps tendon can have tendonitis as well as a complete rupture. The complete ruptures are usually quite dramatic, and I'll show pictures of those, nothing too scary, but they're usually quite dramatic and very often sound like a pair of jeans ripping or something popping that the person standing next to you could hear. It's usually doing something quite physical with the elbow fully extended or bearing greater weight on our arm as if we were carrying a couch and our partner decided they were going to drop their side and you got the whole couch at the same time. Ruptures tend to have significant pain and cause anterior or front of the elbow pain and swelling, which again is usually immediate and usually quite traumatic. This diagram shows us our biceps tendon muscle and our biceps tendon, which is the distal tendon at the front of the elbow. And the ruptures, unlike this picture, the ruptures usually occur right at the end of the biceps tendon where they anchor into the bone. Much more common in men than in women. And with the suspicion of this type of injury, obtaining a proper physical exam and likely an MRI is very critical to getting a timely repair of that tendon. And I'll show examples of why. When looking at the elbow of someone that had a biceps tendon rupture, we see retraction or bulging of the bicep muscle. We can sometimes see bunching or puckering of the skin at the front of the elbow. This is where the tendon has pulled free and has been retracted up into the arm away from its insertion in the forearm and the front of the elbow, but still has some pull on the skin itself, and it can create these creases and wrinkles. Swelling and bruising is usually quite dramatic and can be purple, black, and blue within a day or two. Tendonitis, on the other hand, is less dramatic. It is chronic pain in the front of the elbow in that bicep tendon, very much in front, usually more painful when lifting objects, no discrete pop, no dramatic swelling, no event where you had more on that arm than you were expecting. So basically no surprises, just chronic soreness in the front of your elbow that generally gets worse after use. For example, working out, doing pull-ups, working in the yard, these types of things. The difference between this and lateral epicondylitis is this is very distinctly in the front of the elbow. So on MRI, we have two MRIs in this picture. This is the front one. This is the front of the elbow on the left side of this image. And we see this coiled up kind of black snake in the front of the elbow. That would be the retracted and ruptured bicep tendon, which has pulled free, north towards the shoulder, basically, pulled free and recoiled and is now bunched up in the front of the arm. On this right side, we see the very same thing with this coiled snake-like structure. This tendon would normally run all the way down across the front of the elbow and anchor into the bone somewhere in this location. But at the time of its rupture, there was enough force on the muscle to pull it all the way back up to this location where it sits coiled. The reason timing is so important is this tendon starts healing to everything else around it and makes a repair much more challenging. Distal biceps tendon ruptures are almost always surgically repaired. Fortunately, our techniques for surgical repair have improved significantly over the past few decades, and that complete recovery is completely achievable, generally beginning activities, reconditioning, working out, and exercising within about 6 weeks of when that repair was performed. The procedures are done as an outpatient and are usually good for a lifetime. Therapy protocols different from one physician to another and depend slightly on the type and the quality of the repair, how large the tendon was, how solid the repair felt. Generally, the decisions for therapy are going to occur after the repair is done, when the surgeon has gotten a good appreciation for the quality and the quality of the tendon itself and the quality of the repair. But generally, newer techniques, we allow full range of motion and restricted resistance about 4 weeks or so after repair. Tendinitis for the biceps tendon can be very challenging, and on occasion, I would often wish the bicep tendon had completely torn, because the surgical repairs of the bicep tendon generally resolve quicker than the tendinitis. I've had bicep tendinitis myself on both sides, and it can really reoccur without proper stretching before exercise, even over a lifetime. If the tendinitis is consistent and limiting activity, I highly recommend a trial of physical therapy with a good, well-trained occupational therapist or certified hand therapist with modalities such as ultrasound, iontophoresis, and these types of stretching range of motion activities to prevent further return of the biceps tendinitis. And so this is a picture of Maine from the top of Mount Blue, which is in western Maine, on a nice cloudy, pretty day. It's one of the most rigorous 1.5 mile hikes I've ever done. It's almost straight up. You feel like you're basically hiking on top of the moon. But the view from the top is really quite pretty. That's Lake Webb, which is outside of Farmington, Maine. Nice, pretty day. And very often when it's 90+ degrees here and 150% humidity, I would much rather be there. So we'll stop with the presentation, and certainly I hope there's some good questions to answer, and I would be more than happy to go through those. So I am a big fan of any kind of modality or any kind of treatment that involves conservative care, and certainly that's what I would choose. That's what I would choose for myself under all circumstances. I'm a fan of acupuncture as well. Now, acupuncture generally speaking, for lateral epicondylitis and for radial tunnel syndrome can be effective. Another technique that is often or can be used as well is a technique called dry needling, which is similar to the concept of acupuncture, in that what we're trying to do is we're trying to improve blood flow safely. We're trying to improve nerve function and then trying to improve muscle flexibility. So generally speaking, after an evaluation and a diagnosis of lateral epicondylitis, acupuncture can always be can always be tried, and I believe is especially effective in conjunction with occupational therapy. Those two techniques in particular can be very helpful. But I usually leave that in the preference of the patients that I'm taking care of, and more than happy to suggest a acupuncture therapy. So that is generally speaking with their thumbs. So this is one of those conditions where deep tissue work, a very deep massage, is generally how we're going to do that. That's going to be direct pressure and massaging of that supinator muscle in the location where the muscle and adhesions are, to physically, and you can imagine just sweeping away cobwebs, and that's basically what we're working on doing. We want to make sure also that our flexibility of our elbow is good, both rotation of the wrist as well as kind of extension or fully straightening and flexing the elbow. But proper treatment of posterior interosseous nerve problems and radial tunnel syndrome involves a lot of manual work in those locations to break free those adhesions, to physically loosen, just like after a deep massage, to loosen the tightness and the pressure on that supinator muscle so that the nerve can appropriately glide and function. That is a fantastic question. So you'll see recommendations for both, and I'll give you my common answer to that is whichever one feels better, and that's not particularly joking. Sometimes patients with very severe kind of lateral epicondylitis and severe pain, heat actually, and the increase in swelling and blood flow that goes along with heat can kind of increase the symptoms and the pain that they have right at that moment. And they very much dislike the sensation of that increased pain and the heat. They will generally choose ice. Some people, on the other hand, and actually much like myself, I don't particularly care for the feel of ice on those parts that hurt, particularly when it's a chronic problem. Generally, for me, I enjoy a nice warm heating pad over that location, and then stretching after the muscles are warm. But in general, heat is going to work better before stretching and before a workout, before exercising, or before working, particularly when we have a job that's more physical. Whereas ice is going to be better at the end of the day when we've aggravated those tendons, we've made those tendons tighter, and we've increased the swelling and discomfort from a hard day's work. Ice will generally help soothe those angered nerves and swelling better than the heat will at the end of the day. But in a generalized way, whichever one feels more comfortable is probably the one that we're going to be more compliant, or we're actually going to be doing. And so whichever one feels better is appropriate. %, yes. Tennis elbow is generalized, or is a more general term for lateral epicondylitis. Although I can count on one hand, specifically it would be 4 times that what I was taking care of was in a tennis player. It's just much more common, honestly, for the everyday things that we do. I'm more than likely going to be the person walking out of the grocery store with my palm facing down, carrying 10 grocery bags in one hand because I'm messing with my keys on the other hand. And I don't want to make multiple trips or bring the cart back. Well, in this position, that's going to aggravate my lateral epicondylitis. And although you might see me walking through the parking lot carrying the bags that way, what you're not seeing is when I get into my car, I'm stretching my elbow out because my lateral epicondyle hurts. So it's more the everyday things that are going to aggravate it than tennis itself. Tennis is actually quite safe to play. But tennis elbow is another name for that. Now, golfer's elbow is a similar problem on the inner part of the elbow. That's the part closer to our body, and it's a very similar kind of stretching treatment modality, physical therapy way of taking care of it, and responds very well to those modalities as well. Coincidentally enough, the timing of those questions was perfect because that can be medial epicondylitis. When there are no nerve type symptoms, which would be burning, tingling or numbness radiating or running down from the elbow towards the pinky fingers. And the symptoms that you're having are mostly pain, discomfort, and tightness or stiffness first thing in the morning. More than likely, the tendon itself on the inner part of the elbow, medial epicondylitis or golfer's elbow, is more of the problem. That can usually be relieved with stretching in particular. But if it's a persistent problem, getting an evaluation done would be important. An X-ray of the elbow to be sure that there's no arthritis, because that can be more severe on the inner part of the elbow, and then beginning a good physical therapy plan. Iontophoresis is when we're using ultrasound as a method to deliver cortisone as a topical application on the outside of our elbow. The ultrasound actually increases the ability for that medication to get through our layers of our skin to the tendons underneath. Usually that iontophoresis is done with a prescription for the actual cortisone medication, which then the physical therapist applies to the outside of the elbow with the help of ultrasound to actually increase the ability for that medication to get under the skin and improve the inflammation underneath it. Stem cells, generally speaking, age is one of those things that actually matters if we're talking about autologous or stem cells from our own body. And so age is not a particular thing for the treatment of lateral, medial, or cubital tunnel syndrome. Age is not a particular concern of mine as far as resuming activity or how these happen. But age is one of those things that matters when we're talking about autologous stem cells. The reason for that is we're using our stem cells throughout our daily lives to repair our bodies in all the kinds of ways that we get injured and that we break our bodies down. Those stem cells are getting activated like soldiers to go into the injured portion and help become whatever cells they need to repair what we need to repair. And over time, we deplete that supply of stem cells. Now, it is possible to use allograft stem cells, which are stem cells harvested from another source that are not in your body. And there's a considerable amount of research being done on those techniques. Platelet-rich plasma is completely safe and still useful to use almost across any age, and can be a good adjunct or a good kind of support treatment in the context or in assistance with physical therapy. So if we're talking about cortisone injections, specifically for the conditions that I was talking about today, that would be mostly for lateral epicondylitis. So I absolutely, and I hear, not every day, but I hear frequently that, a patient or someone a patient knows got a cortisone shot in the outside of their elbow and their pain went away and never came back. And that's wonderful. But more frequently, I hear that a cortisone injection worked, but then 6 months later, the pain came back and now the pain won't go away at all, even with physical therapy. I had a patient yesterday that exact way. And so because of those circumstances, and because there is experimental evidence with research that cortisone injection can actually damage the fibers that make this tendon up, I generally refrain from doing those injections at all. Having said that, I live in the real world. I don't necessarily have time to go to physical therapy, and I'm terrible with doing stretching on a daily basis. And so I understand those other circumstances, and a cortisone shot certainly can remove the pain, at least temporarily, for many people. And so getting a cortisone shot one time, I do think is safe, although not my favorite technique. But getting multiple cortisone shots for that location can actually be damaging. All right. Well, I'd like to thank everybody for participating and for being here. I hope I answered lots of questions and gave people information. And certainly feel free to see me in the office if you had continued pain or any problems that aren't resolving. I'd be more than happy to take a look and get things better.